state insurance commissioners. That's how they said they had to find, these cases.
Right. In fact, I think later today we're going to be hearing from Montana over here, Mr. Lasovich, I'm sorry. Okay, good. That did this. So that'll be a very interesting conversation.
But we really would like, some, as you said, Dana, we need some definition, and the National Association of Insurance Commissioners need some definition, some federal definition as well on what is discrimination. But there are strong discrimination provisions in the ACA, and that is federal. And yes, it says, for the essential health benefits, if your state is not substantially enforcing it, then you go to the federal level. But we feel this is pure discrimination in the benefit design.
I know Larry wants to say something. No, it's good, but I'm going to throw this out there if you can address this too. Why is this happening? Why are the plans getting these generic brand name formulary, brand name non-formulary, and specialty drug tiers? What's happening? Why is that happening?
I mean, I could capital say it pretty simply: cost, fear of cost.
So insurers used to be able to get their money back through the premiums. They can't do that anymore because there's limits on it. So they're going after drug costs and other things that they can get the money. Is that the idea?
Yeah, but I think there's more to it than that, because as I said earlier, it's the same drugs. So some plans are doing it, charging $50. Listen, after $150, people aren't going to take their medications, we find. And, so people are going in January because, there are out-of-pocket limits for the whole year. But, you go to the pharmacy in January and you're stuck with a $1,000 bill, and we're finding people are not picking up their medications. And that's not good. Right. So we really feel that they know people with chronic conditions, need medications, and and so this is a way of not, discouraging people to apply for their plans, and they are choosing to put the out-of-pocket costs on the prescription side. When's the last time you went to the hospital? You could go to the emergency room for a couple hours and it's like $9,000. Well, when's the last time you paid 50%, of that, $4,000 some odd dollars? You pay $200, something, or $300. So they're choosing to put the out-of-pocket cost on the prescription side. And it's some plans, it's not all plans.
That's right. Larry, you mentioned something about
it's really getting back, and Carl said this pretty well. I mean, it's really a way around the pre-existing condition. It's like we can't stop you from getting our plan with the pre-existing condition, and we can't ask you about it. But if you are taking many medications, we'll get you on the back end. And then hopefully you'll choose a different plan because we want healthier people in our plan. And it's all so new out there that
but aren't there mechanisms in the ACA with the risk, I'm sorry, I don't know the exact words.
There's 3 R's, and
yes.
I couldn't tell you what they are.
But there's supposedly these
mechanisms. Risk adjustment.
But there's these mechanisms in the law, and I hope I don't, correct me if I'm wrong, that are supposed to correct for if certain plans have a lot more healthier people than others, right? But you guys don't think that that's enough.
They don't talk about that.
And it's going to take a number of years until this balances out. And as you notice when you go into the exchanges in all different states, there aren't that many options. I mean, everybody is not in yet. People are watching from the sidelines. And even those that are in, when Dr. Philip was talking before about choosing doctors, what doctors are in the system, the number of doctors in the system for the Empire Blue Cross plan for the Affordable Care Act is a lot less than it is for other Empire Blue Cross. And it's gotten better, at my understanding, in year 2 than in year 1, because doctors that were listed in year 1 didn't necessarily take the plan. It was when you got there you found out, no, we don't take that plan.
Exactly, and here in California, you guys may know that the Department of Managed Healthcare, maybe we have somebody here from DMHC, recently found that 2 of our biggest insurers, Anthem and Blue Shield of California, overstated their doctor networks, and in some cases up to 25% of those doctors that were listed on provider lists were not, oh, he's back there, we're not actually on those lists. So he'll be discussing that perhaps. Yes, Liz?
So if we go back to the beginning of even going into the essential health benefits, and even going back to when Schwarzenegger was governor, and he started this whole discussion between individual mandate and guaranteed issue. You know, we were the first organization, we were very new then, and we were the first organization that actually came on to support the individual mandate, the guaranteed issue. And we did that because we knew everybody had to be in the marketplace. If you're going to spread the risk, which is what insurance is all about, if you talk about risk adjustment, everybody's in the system. So you need the healthy people, and you need, and I think some of that education needs to really be, you know, people that are young, it doesn't mean something horrible isn't going to happen to you. You just don't know. Your health, you never know when something's going to happen to you with your health. So everybody needs to be into the system. We wouldn't be having, I think, a lot of this conversation if that really came, you know, into fruition right out the door. And people are still arguing about the individual mandate. Do we have to have insurance? And they're trying to make provisions to keep people, you know, for that to change. So that could be problematic, especially it's a good thing for employers to have all of their employees insured. So there's a lot of room there still to improve it, and I think we'll be able to do it.
Well, that's good. That's a nice positive, you know, future
It's my positive.
outlook. Are there other areas other than, well, this brings up an interesting point to the future. About a week and a half ago, the federal government released proposed regulations, if you guys could discuss, that address discrimination in the plans. Could you guys explain what those are and what they could address, and if you think that there's hope there?
Yeah, so we were really pleased that, you know, we've been complaining about this for the last, you know, over the last year about this discrimination that we feel is discrimination. And we were very pleased that a week and a half ago, there was a proposed rule that came out of the federal government that said, and this was not in the rule, this was in the preamble, but it's, you know, it's stating that they say that plans that put most or all drugs to treat a certain condition are in a class, they would consider discrimination. So that was really great news. That's exactly what we've been saying. And so we're pleased, you know, that they're listening to us. They actually did say last year that they were going to, you know, watch the plans a little more closely, look for discrimination. We didn't see any evidence of that in 2015. So, you know, so yes, they said this, but now they have to enforce it. And so that's the next.
That was going to be my next question. So if they're saying there should be no discrimination, Dana, what's that going to actually mean?
I mean, as I said before, I think that's the key, and I think that's also going to be kicked to the states. I mean, it is great that they're listening, and there's sort of this federal voice that's saying, hey, we want to more clearly define and clarify what we mean by discriminatory benefit design. Give some examples, which I think was really helpful. And I think, you know, they gave examples that were, I think to all of us up here, a pretty clear example of discriminatory. You're putting all medications to treat a certain disease on the highest tier. I mean, that was pretty egregious. You know, in some other disease groups, you know, cancer specifically, I can speak for, you know, there are just hundreds of different types of medications that patients take for hundreds of different types of cancer. And so, you know, we kind of need to know a little bit further, okay, when that's the case, is it then discriminatory for, you know, if there's one type of drug to treat a type of colon cancer, and that's on the highest tier, but it's the only drug that's out there, is that discriminatory or not, if it's only one drug, as opposed to the entirety of the, you know, treatment regimen that treats a specific disease. So I think we have, you know, probably a lot of work to do, not only in defining the additional examples where discrimination exists, but in addition to that, you know, how is that going to be evaluated? And I think the rule also discussed potentially developing a new tool. Currently, HHS gave a tool to states to really just look for, instead of specific discriminatory benefit designs, it was just mostly to look for outliers. So a plan would get pinged if they had a really high cost for a certain tier of drugs, but they would also get pinged if they had really low cost for, say, generic drugs or brand drugs.
So why would enforcement of a federal rule be left up to the states?
Because that's primarily where some substantive enforcement can happen, where really the more in-depth review of plans can happen.
Right, but so would that mean here in California, it'd be this Department of Insurance and the Department of Managed Healthcare? And, okay, I mean,
The
is,
insurance market is basically government at the state
State
level, but then, this is a federal law.
I
as
guess my
well.
real question is would there actually be enforcement?
There
If
should
it-
be enforcement.
Right.
Well, and, Georgetown did a study a couple years ago, but basically the non-discrimination language in the ACA was what a lot of state insurance departments felt was one they had the least ability to enforce currently, just because it was so ambiguous as it was written in the federal law. So I think, again, states may have to sort of codify what the federal law is saying and then add further detail as to how, what that means and how to enforce it.
Yeah, I just want to look at this from a different angle, looking at it from the consumer and the patient point of view. And I think it's the job of all of us in the room and all of us that we know to really be advocating really strongly about why this needs to be in place without these discriminatory practices, because of the results that it'll cause. If people have the right medication and if people adhere to their prescription medication, it will save us dollars down the road, which is what the states and the government want to hear.
Right.
On the other side, more importantly, it will create better quality of life for those patients that are in there. If you, just for example, a point-in-time study that was done at the American Diabetes Association, that diabetes patients, if they adhered better to their medicines, would reduce the number of emergency room visits in a year by 700,000.
Wow.
And would reduce the number of hospital admissions by 300,000, which would be a savings of $4.5 billion.
And in what you're saying, weren't you telling me this yesterday? Isn't there a threshold at which people will stop buying their medications? And you said it was 150, and I talked to Larry about it
There's been a lot of
yesterday.
studies about that. I think this is the real issue. I know we keep on talking about discrimination, but I think the problem is this coinsurance. And, it's just too high. And, people, I could see $150 copay for, many medications that treat certain diseases. But it's this issue of coinsurance and the high patient cost sharing. And we're complaining about that, and we're getting to, the discrimination there. Do you need a towel?
That's okay.
There's a napkin.
Thank you.
So that's the real issue, and it's the high patient cost sharing for
But it's not just for medication. I'm wondering
Right.
if you guys can address, are there other areas in these plan designs that are also potentially discriminatory?
Yeah, I don't know
Or-
that we want to continue to say discriminatory.
Okay.
It may just be too costly.
Too
Yeah,
expensive.
And that's what my
Too
point is,
expensive.
is the
Yeah,
coinsurance.
right.
And I would propose, that we look at, there are some states that have put in place cost sharing limits, like Maryland, Louisiana, Delaware, no more than $150. And, and then there's a federal bill that has 140 co-sponsors that is bipartisan right now, and it says that you cannot charge, and this is inside and outside the marketplace, private plans, no more on the specialty tier than the highest cost for the non-brand, non-preferred brand name drugs. So I think there are solutions out there, and these could be handled at the state level as well, or at the federal level. But I think that is the issue that we're all talking about. It's this use of coinsurance and high patient
That's true,
cost
and
sharing.
I think, Liz is next. She's
I'm being
eager. That in California, at least, I know for the plan benefit designs, that these co-insurances of 30% or 20, 30, 40% also exist for lab tests. And I remember last year telling people, if you're just
Yep.
looking at the premium, you're not looking at the entire cost. What if you have to go in for a lab test? You could get a bill for $1,000 or more at a pop, basically. So if you're paying 30% of it. So that's something, we're gonna go to Liz, but that's something, again, that the culture changes. People have to not just look at the premiums, right? But Liz.
Thank you. So now I've got three things, but I'll give everybody time. I want to read something because this is really essential to everybody in this room, and it was just published like last week. So there is an opportunity for comment right now with U.S. Health and Human Services. And here's one of, I want to just read this really short paragraph. It says, HHS highlights discrimination. Now this is why advocates' voices are so doggone important, because our voice matters, it makes a difference, and we've created so much noise around this issue that they are hearing us. Okay, HHS warns insurers that it is prohibited to design plans in a discriminatory way, and that HHS and/or state regulators may demand that insurers explain their benefit designs. HHS provides examples of discriminatory designs such as limiting access to benefits based on age or placing drugs for a specific condition in the highest cost tier. Consumer advocates have an opportunity to weigh in on developing a stronger, more transparent approach to holding insurers accountable. This is huge, huge. Comments are due by December 22nd. So we're going to be talking more about this.
That's good to know, yeah. I think this room is probably filled with some advocates, so that's good for them to know.
When I hear Liz say this, I'm just really glad I'm on her side.
Okay, that was one of three. Let's hit the other two, because we're going to have, I think, 5 minutes, and then we have some Q&A from the audience. So.
The other thing that we were talking about in working with the states, and we're talking about as we've developed this national collaborative discussion, some of these other states that Carl just alluded to, like Delaware, oh my gosh, Delaware has such a model. They got their state commissioner to bring everybody together in the room to start having conversations. That included the health plans, you know, the consumers, all the groups together. And at the end of that, they realized that they needed something done in regulation. So together, a bill was passed without anybody opposing it, including the health plans, with a $150 cap on specialty meds, which was huge. There's a model there. And now Pennsylvania, New York, and other states are following in that same, you know, working on that same model. And so we have been in conversations with Delaware and then Chicago, Illinois just did something. So it's happening all over the country as this continues. But at the same time, we want health plans to remain solvent. And so that's another whole discussion of how do we do that. And there are ways to be able to make that happen when we coordinate care, because we've been looking at uncoordinated care and comprehensive medication therapy management that can also lower costs. And we're also talking about medicines that cure, that we haven't even gotten into yet. Sorry, that was more than three.
Oh, I wasn't sure when you got to three, actually. Are we too late for 2015? It's too late for 2015.
These are 2016, so they're talking about.
Okay, so 2016, because I know in California they kept the exact same plan designs for covered California as last year, or this year.
We're finding that the plans look very much like, you know, last year's plans. I think Avalier just came out with a study today that looking at some specialty drug classes that they're using more co-insurance. The percentage has gone up. Yeah, so that just came out today, so you'll probably read about that.
Okay.
So we're seeing, you know, because there was not much action and oversight taken this past year, that they're getting worse. And so we really need to step it up, and they are listening to us. And I would encourage, you know, Liz talked about this proposed rule. There's some other things in there as well that we didn't talk about, like new drugs that are so important. It was kind of, you know, that was one of the first, you know, it's one thing to talk about cost. We have to make sure the drugs that the patients use are on the formulary. So that's number one. And that they are proposing a way that it's not so static, that you could get, by creating pharmaceutical and therapeutic committees that you could meet quarterly. So you could put the new drugs on there and take drugs off formularies too when they're no longer, you know, being used. And so that's positive. They are interested in transparency issues as well. We saw in the video there, you click a zillion times and you still can't find the formularies. So they are proposing in there, and this is in the law. You are supposed to, and this is the summary of benefits that's inside and outside the exchange. You are supposed to be able to click immediately to a formulary. So they have that proposed as well. So there's a lot of things in this rule that we should be commenting on. So we'll be having IM Central will have a sign-out letter. So hopefully you'll circulate that.
So just to quickly reinforce one thing that Carl said there, it's so important for the right drugs to be on the formulary, especially as we're moving towards more personalized medicine, and you get your regimen, your treatment plan, and then you sign up for a plan or any plan, and you have to start switching around the medications that you take to get back to the right regimen for you, and that just needs to be changed.
Dana, did you want to?
Yeah, two other things in that vein that this proposed rule included, one of which was, every plan is required to have an exceptions process. So they may not have your drug on the formulary, probably because you couldn't find it when you were shopping for a plan. But if it's medically necessary, then every plan is required to have a process where you or your doctor can apply for an exception and get coverage for a drug that is not included on the formulary. Problem prior was that if you did get an exception granted, great, but whatever you paid for that drug, it was really unclear whether or not that cost would accrue towards your total out-of-pocket limit for the year, which is a huge patient protection that the ACA affords. So this proposed rule clarifies that if you do get approved for your exception, then anything you pay for that drug, whatever the cost sharing is that's assigned, will accrue towards your out-of-pocket maximum. So that was a huge, huge win, I think. And then secondly, there wasn't a requirement, but I think the language was, HHS will strongly encourage plans to sort of have this 30-day window for patients to maintain continuity of care when they need a drug that's either not on the formulary or requires a prior authorization or any sort of other utilization management that's attached to it. HHS is encouraging carriers to allow the patient to get immediate access to the first 30-day supply of that drug without imposing any sort of, hold because of an exception process or an appeal process or prior authorization, so that patient can, if they're transitioning to a new plan or something like that, would able to get immediate access for at least the first 30 days of that prescription while they go through the exception process or they go through the appeal process or prior authorization. So, while that wasn't a requirement, I think it was a really great thing to throw out there and say that they're going to strongly encourage plans to do, if not maybe require in the final rule. So
Hopefully that will be adopted. And we're going to open to Q&A. Just before we do that, in California, the legislature this year adopted SB 1052. And starting in January, it requires a link to Covered California to link to drug formularies on the plan's websites, but you see how easy and accessible that is. But by 2017, I looked it up, by 2017 there has to be some standard template that is adopted by the state, and the plans have, and that actually has to be on the Covered California website, I believe. So hopefully that'll be easier, but it's still a few years away.
And not an easy bill to get through.
Yeah, I can imagine. Who has questions? I'm hoping some people have questions. Yes?
Like I have a daughter that was born with, she has a 21p plus chromosome, so she has a lot of health needs. Oh, I'm sorry. My name is Cindy, and I have a daughter that was born with a 21p plus chromosome abnormality. So because of that, she has all these other diseases, infectious diseases. But lately, what's been happening in the hospital is that every time she goes in with a pneumonia, she'll come out with all these other bacteria infections. But yet, she's resistant to I barely found out in 2011 that she still has MRSA that was never colonized because she had an allergic reaction to the medications. But yet they haven't done anything to try to help her. And so she's deteriorating because every time we need to get a prescription, or just because I have her at home, because I get Albion care also through the State Department of Health. But what's happening for us is that Every time she needs supplies and there's a medical diagnosis and a medical justification, we go through our insurance and they're not helping us. It's always getting denied, or they're requesting this or that, but yet my daughter's suffering with the pain. She's still not, she has a Baxter. She has MRSA in the sputum. She has MRSA in the kidneys. She has MRSA in the bloodstream. But yet, the hospitals aren't doing anything. Her actual primary doctor had just asked me not too long ago, could I find another physician, because Christina's taking up too much of her time each time we go in for a regular doctor visit or follow-up, because she's she's too much time consuming for the fact is that all the paperwork that comes along with her, and she feels that her other patients are being cheated from that. And she also calls her a petri dish, and I barely found out what that meant because of all the bacteria infections that she gets. And you know, I'm a fighter for her. I also file grievances and complaints with the State Department of Health and Licensing against the hospital, gone to the County Board of Supervisors because it's a county facility that she attends, goes to. And it seems like nobody cares. You know, when she was first born, they gave her 3 months to live, and thank God she's 25. And to me, she has a lot of life still in her, you know, and but thank God that I get the LVN care. And but now the changes that are coming, I get my LVN cares through the State Department of Health and IHO, and they don't. They're supposed to give me 12-hour shifts, and I don't get them completely filled. So I'm doing the 24-hour shifts most of the time.
Cindy, I would love to stay after and talk to you in more detail about that.
Okay, thank you.
Thanks, Cindy. Yes, there's a question right there.
I'm an adult patient and patient advocate who has rheumatoid arthritis. I grew up with it as a child. Some of the time when we're going through our flares, it is very difficult to have the energy to fight for appeals processes. Also, when a biologic drug, for instance, for rheumatic disease patients stops working, it is very difficult to go through the fail first process. It's difficult when your rheumatologist would like to put you on a new biologic, and for instance, the patients that I advocate for, if they're going to be signing up with Covered California, they're not able to see what new drugs are in the pipeline that might be coming out, just so they kind of have a heads up to know what might be covered for them. We don't have the energy when we are sick to do all of that. And I can't speak more to that. I was a working professional in Silicon Valley who constantly, and prior to that, financial services, my entire working life, I had to constantly call ahead of time to find out whether my meds would be covered. It was time consuming. It was lost productivity to the employer when I would take time away to go do that. It was a nightmare. So we need to make things easier for patients. Chronically ill patients cannot do this any longer. We cannot keep fighting any longer like this. We need it to be easier.
So Monica, that's why I'm a patient advocate, because that happened to me back in the early 90s when I was denied access to care. And that's where my passion comes from those roots when you know you're denied. Yep. We've made such progress. There's so much more work that needs to be done, but your voice is so important because the regulators need to hear this, the health plans need to hear this, and then we can work through that to find what are the solutions, because we won't stand by and say there are no solutions.
I couldn't agree more. I mean, just hearing you talk, I cannot give that message. I can speak about similar problems I had on behalf of my father, who was dying of cancer, but I can't give that message the way that you can. And whenever we're working on something, particularly at a state capitol where you can have a lot more sway because it's just a smaller environment, we really the Cancer Society, we really struggle to find patient stories that fit the issues that we're working on. We know that they're out there, we know how powerful they are, but they're hard to find. So, I mean, I think the importance of your story and what you have just said is probably the most powerful weapon that we have to try and exactly look at something like appeals processes and how we can make sure that they happen in 24 hours instead of 30 days. So, you know, I mean, I just cannot tell you, I'm sure you've been told before, about how powerful that is. It can only come from the person who's experienced it, though.
And Dan, on that, it is so powerful, and we've all heard that from the legislators also. It's not just when you listen to it here and you realize how powerful it is. The one-on-one stories, the real stories, the person who comes in and tells why this doesn't work for me and why it has to be different will really make change and make change quicker.
Thank you. One question back there, and then if we have time.
I'm Carrie Harder. I just had a question about quality and what role quality plays and quality measures in the marketplace plans, because there's quality metrics for Medicare, quality measurements for Medicaid, but is there a role perhaps for quality metrics to be reported on in marketplace plans, and then that perhaps would help push marketplace plans to cover more products?
I think the short answer is yes, although I'll probably defer, but also the Department of Managed Health Care has an HMO report card, and that's updated every single year, and it includes, am I right, Liz? It includes plans that are offered through Covered California.
It does, but we can even build on that because some very exciting things are happening. A big grant came to the Department of Insurance, and that grant is now being worked with UCSF. This is all about transparency, quality, and cost, and it's going to cover right now, we just had a meeting a while back, and for some reason I got into data. I got into data, and now I'm data. And it's important, it's really important. But understanding, what does that mean? What does that data mean? What does it mean to the consumer? And so as all of this, there's a lot of transparency that's taking place that hasn't been published yet, but it's being worked on, so it will be published. It's got to become published in consumer-friendly language, so we understand that. What if I need to go have my knee replaced? What is that going to mean? Where's the best place to go? Who has the best results? So that information is being worked on, and it will be transparent soon.
We have one last question right here.
My question is in regards to access, particularly for rural areas where people now, maybe have insurance, as you mentioned, but particularly in rural places where there's lack of specialty providers, there's lack of fairly qualified health centers. Is there any kind of movement to incentivize providers, particularly in rural areas, so that services are more readily available?
Well, telemedicine and working with, my husband just had an experience, and one of the things that the coalition's been working on with Department of Management Healthcare and all the universities around the state is to reduce heart attacks and strokes and complications of diabetes, called the Right Care Initiative. One of the big issues has been going into the rural areas. How do we get out there? How do we get the care that's needed for